Hello and welcome to Community Conversations. My name is Luke Margolis. I'm the Corporate Communications Director for Atlantic Health System. And on this episode of Community Conversations, I am excited to welcome back Dr. Jason Kessler. He is the Section Chief of Infectious Disease at Atlantic Health System's Morristown Medical Center. And this is, we were doing the count before we got started, I think this is your third appearance on our show. So thanks for indulging us once again.
Thank you, Luke. Enjoy to be here once again, and I'm glad to participate.
And we are, we're talking really about the same subject matter that we had on your previous two community conversations. For our astute viewers who have been watching all along throughout all 30 some odd episodes of Community Conversations, we had Dr. Kessler on last, right around April, when cases of COVID-19 were just about at their peak, and then we checked in with him once again a little later in the spring. But a lot has really happened since then, and we thought it would be a great opportunity to have Dr. Kessler back on to sort of take the temperature of where we are right now. There's a lot of stuff happening in the space of vaccines and of variants, so we're going to chat for a little bit and cover some ground. But in addition to my questions, if there's anything that we cover that you want a little more information on or we haven't gotten to yet, please feel free to enter those conversations in text on the text field there on your screen. And then as a reminder, if for whatever reason you got to bail out of our conversation, this entire conversation will live on our social media channels and on our YouTube channel. So subscribe, please. That would be great. And you'll never miss an episode of Community Conversation. And finally, you can go to our website, atlantichealth.org, where all of the conversations live there too. Speaking of questions, we submitted a request for questions and we got about 10 pages in 12-point font of different questions. We will get to as many as we can. We will not get to all of them, so I apologize for that, but we'll try to get to some of the more popular groupings so we kind of do as many as we can. All right, all that having been said, let's jump into it, Dr. Kessler. The majority of the questions we got, the majority of what people are talking about right now is really the most recent news that's out, and that is around the announcement that a small subset of the population are now eligible for a third dose of the mRNA vaccines for COVID-19. Tell us a little bit about who's eligible and what sort of what the value will be for those folks for another dose of the vaccine.
Sure. So as everyone is already aware, there are 3 vaccines that have been approved on an emergency use basis by the Food and Drug Administration for use to prevent COVID-19, which is the illness caused by the SARS-CoV-2 virus. There's the Pfizer and Moderna vaccines, which are mRNA-based, and there is the Johnson & Johnson vaccine, which is an adenovector virus-based, so basically using another virus to insert the information needed for our cells to respond to the COVID virus. Yeah. The Food and Drug Administration and the ACIP have recently put forward guidance that people who are moderately to severely immunocompromised would benefit from getting a third dose of either one of the 2 mRNA vaccines, if that's what they had received.
Moderna or Pfizer.
Correct. Before. We are still waiting for guidance for people who have received the Johnson & Johnson vaccine. So as of right now, we don't know what those individuals will be most benefited by. However, we do know that if an immunocompromised person had received either a Pfizer vaccine or the Moderna vaccine, they would benefit from a third dose. And right up front, I think it's important to make that subtle distinction between what the FDA is talking about and some of what has been discussed in the lay press as far as what's to come. So what the FDA and the CDC and the ACIP have been talking about has been expanding the dosing schedule to a third dose for individuals who are immunocompromised. And the reason that is important is because we know from the science that has been conducted on these individuals is that a fair proportion of them do not respond well to the initial dose of 2 vaccines, which the majority of folks have received.
Non-immunocompromised.
Non-immunocompromised folks. So if you took the non-immunocompromised population, 95 to 100% of people will generate a detectable antibody response to those vaccines. If you look at the population that we're talking about, the moderately to severely immunocompromised population, that percentage drops down precipitously. And so what has been studied is that if we give these individuals a third dose, a significant proportion, but not all, will then mount an immune response, meaning a detectable antibody response.
What is immunocompromised? We got a lot of questions from folks wondering, I had a pacemaker installed. Does that make me immunocompromised? There are certain medications that I'm on. Do those make me immunocompromised? And before you answer, I just want to say one thing. We had a lot of folks who asked really specific questions to their personal medical history, right? Like they had certain surgical procedures or they were of a certain age. Up front, Dr. Kessler and I, and all these community conversations we do, we really do not diagnose individual cases through social media, through Facebook. If you have a very specific question that is very specific to you and your medical history, that is a conversation best had between you and your physician. We will try to provide some general information that is applicable to most folks, but for those folks, and we appreciate the questions that were submitted, if you have a very specific instance that's just really related to you, you really need to ask your doctor about that. But that all having been said, what is immunocompromised? Who is immunocompromised? And what can we empower folks with to make those decisions?
So it's kind of a nebulous term, but it covers a very wide spectrum of conditions, illnesses, and medications that a patient may be receiving or an individual may be receiving. But we're talking about a fairly circumscribed group of individuals when it comes to receiving a third dose right now. And the main populations that are encompassed by the recommendation include those people who have very severe issues with their immune system. And that comprises a few main groups. Mm-hmm. First and foremost are probably individuals who have received either a bone marrow transplant or a solid organ transplant of some kind, and they're on very powerful drugs to suppress their immune system to prevent rejection of the transplant. So that's one group that was clearly addressed by the FDA and the ACIP. Second group would be people who are being actively treated for cancer with particular chemotherapeutic agents or may have active cancer at the time right now. Another group would be people who have other kinds of medical issues that require treatment with immunocompromising medications, such as high-dose steroid medications or other medications for things like rheumatoid arthritis or lupus that are also associated with weakening or suppressing the immune system as a part of their treatment. People who have had other issues like have lost their spleen either through trauma or through other surgical procedures may also be eligible in this regard, because those individuals may be immunocompromised because the spleen plays a very important role in our immunity. Mm-hmm. So that just gives you a sort of array of conditions that has been addressed. There's a spectrum, of course, of what immunocompromised means. So people who are at the advanced age may be somewhat immunocompromised compared to a healthy 40-year-old individual. Somebody who has severe diabetes may be somewhat immunocompromised compared to somebody of the same age who is not diabetic. Again, another example of somebody who would fall into that severe category would be somebody who has uncontrolled HIV disease, who is not yet on medication and is not yet virologically suppressed. So there is a spectrum, but really what this group has done and what the science has suggested is that this group that falls on this sort of tail end of the spectrum is likely to benefit from getting an additional dose of the vaccine right now.
What do we know about everybody else? Because I know that there's the federal government has come out and shared some information about the rest of the body politic at large, the citizenry. What do we know about when everybody else may be able to be considered for something like this?
So I think there's actually been quite a bit of discussion and debate about whether or not other people, the rest of us, mm-hmm. the vast majority of us, will require additional doses or boosters. And I think this is one of the points I was alluding to a little bit before. For the group that's been approved currently, this group of immunocompromised individuals, what they're saying is the dose, this is an additional dose, it's part of the usual dosing schedule. What the FDA is considering and the CDC is considering is making a recommendation for a booster shot. So the difference, it's a subtle difference, but the difference is that in a booster shot, what we're talking about is that we're giving an additional dose to somebody who's already been known to respond to the vaccine because the immunity that was engendered by the vaccine may wane to some extent.
So it's to boost that back up.
So it's to boost it back up.
Yeah.
And it really depends somewhat on your perspective. So I think what the epidemiology of the virus has shown recently through studies conducted not only in the United States but around the world is that in certain populations, and depending on what your outcome is, the vaccine effectiveness has decreased over time. So, but it depends on what you're looking at. So for instance, if you're looking at the likelihood of somebody being vaccinated and then developing such a severe case of COVID-19 that they wind up in the hospital or that they die, well, the vaccines have been remarkably effective in preventing that from happening. And they continue to be remarkably effective in preventing that from happening. It doesn't mean that nobody who's vaccinated will wind up so sick they're in the hospital or that, God forbid, they die, but the vast, vast majority will not. However, there is certainly some burgeoning evidence that whereas earlier in the pandemic, if you were vaccinated, so 6 months ago you were vaccinated, it seems to be that you were much more likely to be protected against infection. So we have to differentiate infection
and severe illness.
And severe illness.
Right.
So many people can be infected and they may not even know they have the infection. They may be asymptomatic or very mildly symptomatic. They may only complain of an upper respiratory kind of illness. That's an infection. I think the vast majority of people are really worried about is getting so sick they wind up in the hospital, they're on oxygen, they wind up on a breathing machine, or God forbid that they die. Mm-hmm. And again, the vaccines, the 2 doses of vaccine that most people have received continue to perform very well in preventing those most severe outcomes.
And that one of the series of questions we got is about breakthrough cases, which is essentially that's the phraseology that's describing much of what we're talking about right now. There are some folks who are saying, look, why should I get vaccinated at all if there's all these breakthrough cases and obviously the vaccine isn't 100%, so why take it? Is any vaccine 100%, or I guess what would your reaction be to those folks who are saying, maybe they're on the fence about being vaccinated because they see and hear breakthrough cases and wonder, look, is that the majority of these cases right now? Are they breakthrough cases? What's your response to that?
Yeah. So I think one of the things, again, that has been noted, and it is likely there are several reasons why we are seeing this, and I can go into a little bit of the detail about that, is that earlier, even 6 to 8 weeks ago, maybe 12 weeks ago, we were not seeing a lot of breakthrough cases. We were seeing some, they're rare, certainly, but certainly within the last 6 to 12 weeks, we've seen a somewhat increased number of breakthrough cases, and that, like I said, has multiple different reasons behind it. However,
we're speaking nationally now. Not specific. This isn't specific to New Jersey. This is national.
Across the country.
Yeah.
And perhaps across the world, anywhere where the vaccines are being utilized.
Sure.
However, we continue to note that the people who are wind up getting hospitalized, the people that wind up on a breathing machine in the ICU, the people that unfortunately wind up succumbing to their COVID-19 illness, far and away, 10 to 1, 20 to 1, are individuals who have not yet been vaccinated. So while there still remains a risk to an individual if they've been vaccinated, the risk overall is much, much less for getting infected, mm-hmm. and the risk is certainly a whole lot less of getting such a severe infection that you wind up getting hospitalized or dying. So what I would say to a person who is questioning the use or the need for vaccination because there are breakthrough cases is, well, there's no vaccine that has no such thing as a breakthrough case. And God forbid you did get infected, the likelihood is the fact that you got vaccinated reduces your risk of getting severely ill or dying of your infection much, much less.
Some of the reason why we are where we are is because of the variants, the variant that everybody is talking about right now, the Delta variant of this virus. I know that we're asking you to consolidate quite a lot of education and a lot of virology into a very brief statement here, but maybe the Reader's Digest version, if you want to call it that. What are viral variants, and could the virus continue could we see another variant after Delta? I guess for folks who are curious about that.
Sure. So viruses have genetic material just like we have genetic material. Their genetic material, this particular virus's genetic material is RNA. And when viruses or humans or any living creature reproduces, their genetic material must be replicated. And the process of that replication is error-prone, meaning there are mistakes that are made when those pieces of genetic material are expanding and being reproduced. Mm-hmm. And those errors create mutations. And it's those mutations that ultimately create these new variants. So there are new mutations that change the structure of the virus in some way that may make it more fit or sometimes less fit. Fortunately, we don't have to worry about the less fit ones because those just kind of die off and they're not really relevant anymore. But every so often, rarely, but it does occasionally happen, a mutation will make the virus better able to infect its host, better able to potentially hurt its host or kill its host. And that is where we see some of these variants and why we see these variants. And because viral replication happens, millions and millions of times each hour, each day in an individual who's infected, you can see that over time you're going to get hundreds of thousands, if not millions, of mutations occurring in a virus, in an individual who's infected. Now, fortunately, most of those mutations are either meaningless, they have no impact, or they're detrimental to the virus and the virus can no longer reproduce effectively. But every so often, you'll get one that actually changes the virus in a way that makes it potentially more infectious or more dangerous.
So how do we stop it? So is there anything we can do to keep that from happening?
Well, I mean, the way to keep it from happening is to reduce the amount of viral infection and replication that's occurring in the community at large. And really, currently, we have two main strategies for doing that. One, and most effective, is vaccination. Two are the strategies that we've been used to and using for the last 18 months, which are the non-pharmacologic interventions, such as social distancing,
right,
masking, hand washing, things that will help us prevent exposure to getting exposed to the virus to begin with. So if we can't get exposed, we can't get infected. And if we can't get infected, the virus can't replicate.
The tried and true stuff you and I even talked about last April.
Correct.
Let's get into some of the questions we've gotten now. One of them is actually, I was surprised at how frequently we were asked this, and that's a lot of folks sort of looking a little further down the line and knowing that there's another virus that usually rears its head sort of in this late summer, fall type time that really becomes an issue as we move through the year, and that's the flu. And a lot of folks are wondering, I usually get my flu shot kind of around now. What do we know about timing of a potential third dose or booster and a flu shot? Is there any information out yet about what we know about those two things and whether or not they should be spaced out, or can you get them around the same time? What do we know about that?
Well, I think we're going to see that there will be another flu shot. There's an annual flu shot that's developed each and every year. Even last year, when while we were very concerned about the flu, there was actually very little influenza circulating because of all the measures that we were taking during the winter time last year, including masking and social distancing. The schools were mostly closed, so the opportunities for influenza to kind of take off really didn't exist. So there will be a flu shot this year, and usually it will be available for use in the early fall. So that will continue this year as well, and it is presumed that the FDA is going to approve a booster shot for COVID-19 for the general population, sort of rolled out in stages as it was initially during the first doses, but eventually everyone would probably be a candidate to get it. So there probably will be an overlap as far as getting your booster shot for COVID and getting the flu vaccine. Right now we have to wait and see if there's any evidence to suggest there would be any problem about administering those two vaccines together. But up to this point, the evidence that we have is that the COVID shot, the COVID vaccines that are available, do not have any additional side effects when administered with other vaccines in close proximity. So it's likely to be safe.
And again, to reiterate, the public health guidance that we know worked against that works against COVID-19, masking, hand washing, also just so happens to be the same public guidance that can help with the flu. So
Correct.
it seems like it has that added benefit
Correct.
as well. We have, again, a thanks to everybody who's been submitting questions. We have a ton of them. I do want to, again, remind folks that individual specific questions related to their personal medical history best discussed between you and your physician. Again, regarding distribution of vaccines, we have some questions here about whether or not the mega site that Atlantic Health System operated in collaboration with Morris County and the state, just like the other 5 other mega sites that existed around the state, whether or not that will be reopened. At this point, there's no information from the state about whether or not those sites would be reopened. However, if you are moderately to severely immunocompromised and are curious about where and how you can get a 3rd dose of the vaccine, go to our website, atlantichealth.org, and you will see a link on the homepage there for information about scheduling 3rd dose appointments for those specific people who are immunocompromised and are currently recommended for that. What happens with the conversation we just had about whether or not in mid-September the recommendation is broadened out to the larger group? We'll have to wait and see when that comes down. Know that we will communicate to all of our audiences, both on programs like this, through social media, on our website, through email. When we have that information, we will share it with you. So, but at this point, that is not recommended. One of the questions we got around is around FDA approval. So there are some folks who are saying, look, I have family members who are saying, I'm not getting vaccinated until this is fully approved by the FDA. Why does that take a long time? What's going on, and what are they looking into, and what will that mean when the FDA has officially approved it?
So the FDA has a very set standard process for how they evaluate vaccines, and it's, I would say, even more rigorous than the manner in which they evaluate other therapeutics like medications for chronic medical conditions or other devices even, because they generally are administered to a wide part of the population, and generally they're administered to healthy people who don't have the particular problem for which they're being vaccinated. They're being vaccinated to prevent that problem. So the FDA really wants to be very certain that this is a safe intervention without a lot of potential for side effects. Now, of course, the reason that the vaccines were granted emergency approval was because we were in the midst of a potentially once in a lifetime pandemic.
Hopefully once in a lifetime.
Hopefully once in a lifetime. And so, the risks of waiting for longer until more data was available was certainly outweighed by the benefits that were demonstrated to be provided by vaccination from the phase 1, 2, and 3 trials that were done for the 3 vaccines that they granted that approval. But moving forward, to get full approval, usually they require at least 6 months of post safety data. So we've certainly crossed that threshold as of now. It's been more than 6 months since the first doses were handed out and the clinical trials were completed. So, but not only do we need that safety data, the FDA also needs to evaluate and review the manufacturing processes for all of these vaccines at all the different sites at which they're manufactured. So there's a lot of moving parts behind the scenes, but I think that in relatively short order, certainly by the end of the year, it would be expected that they're going to be granted full approval.
The treatment of people with COVID has evolved pretty significantly since where we were last spring. How successful have we gotten at caring for patients with COVID? What have we learned, and what should people know about our ability, not just at Atlantic Health System, but as a healthcare field, about our ability to care for patients who have this virus?
Yeah, I mean, we've learned a tremendous amount about caring successfully for patients who suffer from COVID-19, and that has played a significant role in driving down the rate at which people suffer severe illness or mortality from the disease. So we now have a cocktail, potentially, of medications that we can use to treat patients who get hospitalized with COVID-19, and we have medications that we can use to treat patients who are at high risk of decompensation as an outpatient if they are suffering with mild illness with COVID-19. And we even have medications to prevent people who are exposed from COVID-19 from getting infection or disease if they are also at very high risk. So I'm talking about things like the antiviral medication remdesivir. I'm talking about medications that modulate our immune system, like steroid medications. And most notably recently have been the development and refinement of the monoclonal antibodies that have been put on the marketplace for both the treatment of mild to moderate disease as well as the prevention of COVID-19 if one is exposed to it for a certain population of individuals.
So, in fact, that is perfect timing. Janice was just asking if we offer monoclonal antibody treatment at Atlantic Health System, and we do. With regard to what we know at this point of the vaccines, are people encouraged to get the same one that they received previously? So if you're immunocompromised and you received Pfizer or Moderna earlier, I think at this point for the immunocompromised, I think they're suggesting it needed to be 28 days or something along those lines between the second dose and now. Do you need to get the same one that you got previously?
That's the way has been approved currently. So if you had received Pfizer, if it's possible to get the Pfizer vaccine as the third dose, that's what should be administered. And similarly, if you had received 2 doses of the Moderna vaccine, and it's past a month from your second dose, if you're severely immunocompromised, you should be vaccinated with the Moderna vaccine. However, if there are supply issues with one or the other vaccine, it is possible to get the opposite one or the other one if there's a supply chain problem. So if for whatever reason there's no supply of Pfizer and you had gotten Pfizer or received Pfizer before, it would be safe for you to receive the Moderna vaccine rather than not getting the vaccinated at all or waiting some indefinite period of time to get the other vaccine that you received.
How are the vaccines, and are we able to modify the vaccines to keep up with variants? How do you if it should mutate again, does it move you all the way back to square one as it relates to vaccine production? Scientifically speaking, again, is there a chance that the science can stay at least alongside the variants, if not one step ahead? Are we reaching like science fiction type territory here?
No, I mean, I think one of the tremendous advances has been the technology that has brought us these vaccines. And one of the significant advantages of this platform, of this technology, specifically the mRNA technology, is it is relatively straightforward to modify the vaccine and to account for new variants and potentially, again, this is somewhat a little bit farther off into the future, potentially to develop vaccines that would engender a response, an effective immune response to a broad array of very similar viruses. So that is something I think that people are looking forward to in the future. Certainly not something that we have available to us at the present time, but there is certainly evidence that under certain circumstances, such vaccines could be developed in the not too distant future.
We are running out of time, but I just want to reiterate one thing, a question that just came up that we answered earlier, but I think it's worth reinforcing. The difference between a booster shot and a third dose. Again, so for our folks who may be just tuning in again, remind them again, a booster is for those who have shown strong immunity and it's ramping back up. Let's explain that one again.
Yeah, so and then essentially for a person sitting at home, at the end of the day, it's going to feel the same thing. You're going to get the same thing. You're going to go into the vaccine center. You're going to go into the pharmacy. You're going to go into your doctor's office. You're going to roll up your sleeve and they're going to give you the same shot you got, whatever it was, 3 months ago, 6 months ago, whenever. So from a practical standpoint, it's going to look the same, it's going to feel the same, and you may have the same reaction if you had a reaction to begin with. But there is a subtle difference. The reason why the vaccine, a third dose, has been approved for the immunocompromised population is that many of them have not developed an appropriate protective immune response, whereas the vast majority of us who are not immunocompromised have. So 95 to nearly 100% of us who are vaccinated with the Pfizer or Moderna vaccines will have detectable antibodies to COVID-19. Whereas, again, if you had, let's just say you were being treated for cancer and you were on chemotherapy, the chances of you developing those antibodies is somewhat reduced. It's not 95 to 100%, it may be closer to 60 to 70%, or sometimes even lower depending on what your risk factors are. So, for instance, solid organ transplant patients, or patients who have blood malignancies like leukemia. Again, they have even lower response rates to the vaccine. So it's a subtle difference. So in those patients, we know, based on the clinical studies that have been done, if we give them a third dose, we increase the rate of response. Whereas for the immunocompetent people, so the generally relatively healthy folks, well, they've already developed an immune response, but that immune response may be waning, as evidenced. We had touched on it. There's evidence that that immune response is waning because the incidence of breakthrough infections is slowly increasing. Now, again, as I think I touched on a little bit, there's probably multiple reasons why that's the case. It isn't simply that the immune response to the vaccine is waning. It's also coinciding with the fact that we're now dealing with a more transmissible, more contagious version of COVID-19, particularly right now.
The Delta variant.
The Delta variant. And just prior to the Delta variant becoming prevalent in the United States, we really started backtracking on all of the previous non-pharmacologic interventions and recommendations. So we sort of relaxed some of our masking practices. People sort of
gathering in groups again,
traveling again. So we kind of took a step back from all the things that we were doing, and I think appropriately so. But if you expose yourself more to the virus, even if you're vaccinated, you're more likely to get the virus or get infected, even if you're still somewhat protected.
Folks, we covered a lot of ground here today, and I appreciate all the questions we received, and I know we did not get to all of them, so I'm sure there are many of you out there wondering, what gives. I would suggest submit those questions in the chat. We have a team of folks who are monitoring, and we'll try to get to answer as many of those as we can. Dr. Kessler and I could be here all day and probably not get through all the questions we got. So, but I do appreciate them, and we do thank you for watching us. Dr. Kessler, trip number 3 for you on Community Conversations. Thanks for joining us again.
Thank you.
All right, folks, appreciate you joining us today. If you missed any portion of today's conversation, check it out on our social media pages, on our website, atlantichealth.org, or on our YouTube channel, and do not forget to subscribe. I'm Luke Margolis for Dr. Jason Kessler. Thanks so much for joining us. We'll see you next time.